And so it's now my pleasure to introduce Dr. Eric Jacobson, who's the clinical director for the lymphoma program at the Dana-Farber Cancer Institute, and he is going to cover both lymphoma and multiple myeloma today. So thank you so much, Eric.
Thank you, Wendy, and good afternoon, everyone. I know I am the only thing standing between you and freedom this afternoon, besides the moderator panel, so I will try to end on time. I would argue that probably no field in oncology has seen more rapid therapeutic advances than lymphoma or multiple myeloma. We won't focus a lot on therapeutics today, but it certainly has been an exciting time to be in this field. These are my disclosures. Today's agenda will discuss briefly the classification of lymphoid malignancies. We'll discuss their presentation, workup, and staging, highlight some important and serious potential complications from these diseases. I'm not going to spend a lot of time on individual subtypes. There are over 60 different subtypes of non-Hodgkin and Hodgkin lymphoma combined. It'd be well beyond the scope of this talk to discuss them all. But I will discuss the two most common non-Hodgkin lymphomas, diffuse large B-cell lymphoma and follicular lymphoma, as well as Hodgkin lymphoma in general. And then we'll finish up with an overview of multiple myeloma. Not surprisingly, lymphomas are malignancies of normal lymphoid cells, which typically reside in normal lymphoid tissue, which would be lymph nodes, spleen, and marrow. Although, given the fact that lymphoid tissue is spread throughout the body, lymphomas can and do present just about anywhere anatomically. The World Health Organization classifies lymphomas based upon morphology, although that's really becoming somewhat antiquated. And increasingly, we categorize lymphomas based upon immunophenotype and predominantly cytogenetics and other molecular findings. We always joke that pathologists are becoming like radiologists, as they frequently suggest clinical correlation in the context of a lymphoma diagnosis, but a number of lymphoma entities do require specific clinical scenarios to establish the diagnosis. Non-Hodgkin lymphomas can broadly be broken down into B-cell and then T-cell and NK cell malignancies. B-cell non-Hodgkin lymphoma accounts for about 90% of lymphomas encountered in North America. T-cell and NK cell malignancies are more common in Asia, parts of Africa, and parts of South America, but infrequently encountered in this country. Both entities, B and T cell, are broadly subcategorized into precursor versus mature neoplasms. Precursor neoplasms are generally acute leukemias or lymphoblastic lymphomas. These are very aggressive diseases. The mature B and T cell lymphomas are by far the most common and most varied, and are the ones that we most commonly encounter in clinical practice. Hodgkin lymphoma, actually I have to update this, is no longer classical Hodgkin lymphoma. It's now called classic Hodgkin lymphoma. That constitutes 4 subtypes: nodular sclerosis, by far the most common, and as the name implies, characterized by extensive sclerosis within the biopsy specimen. Mixed cellularity, lymphocyte-rich, and lymphocyte-depleted Hodgkin lymphoma are all relatively uncommon. All 4 types of classic Hodgkin lymphoma are treated the same, and that's why they're lumped together. Nodular lymphocyte predominant Hodgkin lymphoma is a very rare disease. It behaves and is treated much more like an indolent B-cell non-Hodgkin lymphoma, so it's biologically very different from classic Hodgkin lymphoma, and we otherwise really won't focus on that entity during the course of this talk. This is a schematic of both B and T cell development. I would be shocked if you were ever asked this on an internal medicine exam. If you are, you should ask for your money back. Nor should you bother to memorize this. This is really just to indicate that lymphomas are characterized by the major cell of origin, so that being B versus T cell, and then also the phase of development. So there are certain pre-germinal center, germinal center, and post-germinal center B-cell neoplasms, for instance, and then what are called peripheral or mature T-cell lymphomas derived from T cells that have passed through the thymus. So they're a more late-stage T cell. There's a common misconception that peripheral T-cell lymphoma refers to an anatomic location. It does not. It refers to the stage of development of these post-thymic T-cells. The presentation of lymphoma, not surprisingly, lymphadenopathy, although if you look, only 2/3 of patients actually present with lymphadenopathy. So 1/3 of these patients will have extranodal presentation. So a high degree of suspicion needs to be maintained for these diseases. B symptoms are common to varying degrees. They're more common in aggressive lymphomas and Hodgkin lymphoma, less common in indolent lymphomas, particularly at presentation. By definition, B symptoms are fevers greater than 38 degrees centigrade, drenching night sweats, and unintentional weight loss of greater than 10% of body weight over the preceding 6 months. So very specific criteria for B symptoms. Extranodal sites, as I mentioned, are quite common. The most common are the GI tract, so we do get a fair number of referrals from gastroenterologists. Skin, where these lymphomas often present as erythematous papules, not dissimilar to insect bites. And then bone lesions, which are typically lytic, although occasionally can be blastic, and again, can often mimic metastatic solid tumor malignancies. Rare sites of involvement include the kidney, bladder, adrenal gland, heart, lung, breast, testes, and thyroid. Each of these lymphomas that present in each of these locations often have unique biology, and there are certain treatment considerations for lymphomas that occur in these areas. Again, that would be beyond the scope of this talk, but there are some important considerations when we see lymphomas in these extranodal sites. The differential diagnosis of lymphadenopathy, as you know, is broad, infection being foremost amongst them. I see a lot of patients who are worked up for cat scratch disease, Bartonella, before coming to us. I've yet to see an actual case of Bartonella, maybe because those patients never make it to oncology. It's been my experience that infectious causes of lymphadenopathy typically are not subtle, and in most cases, the patient has an identifiable infection as the cause for their lymphadenopathy. Medications can cause so-called pseudolymphoma. Phenytoin is the classic. Hydralazine can also do this. Occasionally, patients who are on chronic sulfonamides or penicillin for antimicrobial prophylaxis can also develop pseudolymphoma, but by far and away, when I've seen it, it's typically with phenytoin and hydralazine. And these pseudolymphomas often have a characteristic histologic appearance, so the pathologist will often make the diagnosis, but there is a danger of overdiagnosing lymphoma in these circumstances. Rheumatologic illness commonly causes low-level lymphadenopathy, though typically not bulky lymph nodes. So if you see lymph nodes in particular larger than 2 or 3 centimeters, even in a patient with a known rheumatologic diagnosis, that should raise the suspicion for lymphoma. Of course, rheumatologic illness itself is a risk factor for developing lymphoma, and many of the therapies used in rheumatology are also risk factors for lymphoma. So these patients can be very difficult to evaluate and often need to undergo multiple biopsies to rule in or rule out lymphoma. And we often have discussions with rheumatology in patients who have a diagnosis of lymphoma in the setting of rheumatologic illness as to what therapies may or may not be safe to use in that setting. And then there are a variety of other diseases that can cause lymphadenopathy. You always need to maintain a high degree of suspicion to diagnose lymphoma, but also need to be cautious not to overdiagnose the disease. When patients do proceed to a biopsy, fine needle aspirates really are frowned upon in lymphoma. They can be useful in solid tumors, but if there's a suspicion for lymphoma, if at all possible, I would avoid fine needle aspirate. The selection of lymph nodes to biopsy is often triaged by location. Supraclavicular lymph nodes are unlikely to be benign and therefore a preferred site for biopsy. Cervical and axillary lymph nodes are next in the hierarchy of most likely to be abnormal, particularly axillary nodes. And then inguinal nodes are the most likely lymph node group to be reactive, and then therefore often the least favored site for biopsy if other options exist. Of course, you have to sometimes just select the most accessible or safest area to biopsy, but this would be a general hierarchy for how you would select lymph nodes to biopsy. Excisional biopsy is preferred when possible to give the pathologist adequate tissue to work with to establish the diagnosis and perform ancillary studies such as cytogenetics and immunophenotype. A CT-guided core needle biopsy or ultrasound-guided core needle biopsy is acceptable. An excisional biopsy is not safe or not feasible. And when these patients have samples sent for pathology, it is always important to request immunohistochemistry and flow cytometry, and now increasingly genetic and molecular studies. Typically, you would have the guidance of an oncologist and or a pathologist when making these determinations as to what test to send. In terms of further workup, CT scan of the chest, abdomen, and pelvis is critical to evaluate all areas of potential lymphoma involvement, both nodal and extranodal. PET scan has achieved an increasingly common role in the staging of lymphoma, so it often upstages patients. We identify areas that were not appreciated on PET, and on CT, and PET scan is particularly important now for assessing response to therapeutic interventions. Bone marrow biopsy is actually performed less frequently now, as PET scan is often quite good at detecting bone marrow involvement for many histologies. So for instance, in Hodgkin lymphoma, we rarely perform bone marrow biopsies anymore because PET is very good at discerning bone marrow involvement. And then basic labs, CBC, renal function, liver function, uric acid to assess for evidence of spontaneous tumor lysis syndrome, electrolytes, calcium. As you know, patients with malignancy can have hypercalcemia. Beta-2 microglobulin can be prognostic in indolent lymphomas. It's not critical as part of the workup. It's often sent by the oncologist. But if you happen to think of it, it's helpful for us to have this information when we first meet the patient, since it is prognostic. And then LDH, or lactate dehydrogenase, is prognostic in many lymphomas. Again, we can easily send this if we don't have it available when we first see the patient. But if this is sent to us in advance, it can help us provide additional prognostic information and can sometimes help differentiate the possibility of an aggressive from an indolent lymphoma, as LDH is much more likely to be elevated in aggressive processes. And then a serum protein electrophoresis can be important in Waldenstrom's macroglobulinemia, aka lymphoplasmacytic lymphoma, where elevated IgM is very common, and then also in CLL, SLL, where hypogammaglobulinemia is particularly common. Staging system for lymphoma still is the old Ann Arbor staging system. Stage 1 disease would be a solitary lymph node site or solitary lymph node group, with stage 1E being a solitary site of non-lymph node involvement. Stage 2 would be multiple lymph node groups affected, but on the same side of the diaphragm. Stage 3 would be involvement of lymph node groups on both sides of the diaphragm. And then stage 4 would be non-lymph node involvement, so extranodal involvement in the presence of diffuse lymphadenopathy. We already discussed the A and B nomenclature for the Ann Arbor system, although the A and B is actually no longer used as part of non-Hodgkin lymphoma staging. It's only retained in Hodgkin lymphoma staging because Hodgkin lymphoma is the only setting in which the presence or absence of B symptoms is prognostic. Serious complications of lymphoma are varied. Cord compression, often the most feared, so patients presenting with generally lower extremity weakness, bowel or bladder problems, certainly a high suspicion for cord compression should be maintained in that setting. Pericardial disease or tamponade can occur, particularly in Hodgkin lymphoma, which tends to present with bulky mediastinal lymphadenopathy, or a variant of diffuse large B-cell lymphoma called primary mediastinal large cell lymphoma that also presents with bulky lymphadenopathy and pericardial invasion. Hypercalcemia can be from bone lesions or from peripheral conversion of vitamin D, essentially causing hypervitaminosis D, leading to hypercalcemia. Just as with pericardial disease and tamponade, patients can get SVC syndrome or airway compromise, again, most commonly in lymphomas such as Hodgkin lymphoma that manifests with bulky mediastinal lymphadenopathy. Hyperviscosity syndrome almost exclusively occurs in the setting of lymphoplasmacytic lymphoma, aka Waldenstrom macroglobulinemia. The most sensitive and specific finding for this is actually box scarring of the retinal veins. So the retinal veins have a very specific appearance. I think most of us can't appreciate that if we're not ophthalmologists, but this can be a very specific ophthalmologic finding for hyperviscosity, along with the typical cardiovascular symptoms and neurologic symptoms that can mimic CVA. Patients can get mechanical obstruction of the ureters and intestine from bulky adenopathy. Spontaneous tumor lysis syndrome can occur in aggressive B and T cell malignancies. So this sometimes happens even in the absence of cytotoxic therapy. And then particularly in low-grade histologies and most notably in CLL, ITP and autoimmune hemolytic anemia are well described. In fact, a few weeks ago, I had a MICU consult for very severe autoimmune hemolytic anemia and a previously untreated low-grade lymphoma. So it's an uncommon but potentially devastating complication for these patients. Risk factors for lymphoma, occupational and environmental often go hand in hand. There's a recent settlement with Bayer/Monsanto alleging that the weed killer Roundup with the active ingredient glyphosate caused lymphoma. So patients, for instance, who are landscapers or groundskeepers at golf courses may have had high-level exposure to certain herbicides and pesticides that could contribute to the risk of lymphoma. Radiation therapy and chemotherapy are potential risk factors for lymphoma, although they're much more prominent risk factors for solid tumor malignancies. Immune dysfunction, as I mentioned, autoimmune disease, immunodeficiencies, such as occurs in HIV/AIDS, or chronic immune suppression from organ transplant, both hematopoietic and solid tumor transplant, are well-described risk factors for lymphoma, particularly EBV-positive lymphomas. And then genetics do play a role. In general, we have not identified any recurring germline genetic abnormalities that increase the risk of lymphoma, with rare exceptions such as Lee-Fraumeni syndrome. But it is clear that first-degree relatives with a history, patients who have a first-degree relative with a history of lymphoma are at increased risk of lymphoma themselves, although at the moment there's no special genetic testing or screening testing that we would perform in this patient population. There are a variety of infectious associations with lymphoma, the most common being EBV. In fact, for NK T cell lymphoma, by definition, EBV has to be present to establish the diagnosis. The same is true for adult T cell leukemia lymphoma, which can only be diagnosed in the presence of HTLV1 expression. That virus is uncommon in this country, so the entity is uncommonly found in the United States. And then HHV8 is almost always present in primary effusion lymphoma and large cell lymphoma associated with Castleman's disease. The lymphoma most frequently associated with infectious agents would be marginal zone lymphoma, which is associated with a variety of bacteria and hepatitis C. It's important to note that treating the underlying infection in marginal zone lymphoma will often eradicate the lymphoma. So this is important not only diagnostically in this setting, but also potentially therapeutically important, particularly now with hepatitis C and the effective therapies that we have for hepatitis C. Non-Hodgkin lymphoma in general, if we lump all cases together, there are about 75,000 new cases in the United States with 5-year survival of about 70%. Most patients are over the age of 65 at diagnosis, so this tends to be a diagnosis of older patients. And if we lump them all together, non-Hodgkin lymphoma is the 7th most common malignancy in this country. There's some broad truisms that we can make about the clinical behavior of non-Hodgkin lymphomas. Indolent non-Hodgkin lymphomas are not curable, but survival, even untreated, is often measured in years, and to be honest, frequently decades. Follicular lymphoma would be the most common of the indolent non-Hodgkin lymphomas. Aggressive and highly aggressive non-Hodgkin lymphomas can be fatal within weeks to months if untreated, but are potentially curable with cytotoxic chemotherapy. So jumping into indolent lymphomas, this is a list of the various histologies. Again, really probably not a need for you to memorize these at this point, but suffice it to say that a lot of these have shared biological and clinical features, so they overlap in terms of biology and management. There are some indolent T-cell lymphomas, though most tend to be aggressive. T-cell LGL can mimic CLL, so it often presents with lymphocytosis, but is generally characterized by marked neutropenia in the absence of recurrent infections. So patients are able to mount a neutrophil response in response to infection. And then mycosis fungoides or cutaneous T-cell lymphoma can mimic or be mimicked by benign skin conditions such as psoriasis or eczema, and is often a difficult disease to diagnose. Aggressive lymphomas tend to present in an aggressive fashion, so night sweats, rapid development of lymphadenopathy. The most common is diffuse large B-cell lymphoma. Follicular lymphoma I mentioned as an indolent histology, but there is a subtype of follicular lymphoma, grade 3 follicular lymphoma, that behaves like an aggressive lymphoma. And then various peripheral T-cell lymphomas and anaplastic large cell lymphoma also present in an aggressive fashion. And an entity that's uncommonly encountered in the US, NKT cell lymphoma, often causes a tremendous amount of local destruction within the sinonasal cavity and has a very unique clinical presentation with obliteration of the sinuses and the hard palate. The highly aggressive lymphomas, Burkitt lymphoma, the most common, though rare. We see this in the context of immune suppression, also in HIV. There's endemic Burkitt's that most prominently was described in Africa by Dennis Burkitt. And then sporadic Burkitt's, which is the most commonly encountered subtype in this country, which is typically not EBV or immunosuppression associated. And then precursor B and precursor T lymphoblastic lymphoma present like and are treated much more like acute leukemias. The notable thing about precursor T lymphoblastic lymphoma is it generally affects young men and often manifests with a large mediastinal mass and relatively frequently has testicular involvement. So it's on the differential diagnosis of anterior mediastinal mass and testicular tumors in young men. And then adult T-cell leukemia lymphoma, as I mentioned, is associated with HTLV1, rarely encountered in this country, often characterized by lytic bone lesions, hypercalcemia, and a leukemic phase, so a very aggressive malignancy. I'm going to speak briefly about diffuse large B-cell lymphoma. It is the most common subtype of non-Hodgkin lymphoma, constituting about 25% of all non-Hodgkin lymphoma. It does have a male predominance and a median age of presentation of 65. CHOP chemotherapy was originally developed in the 1970s for this entity, and through the 1980s and 1990s and into the 2000s, a variety of more aggressive treatments were developed, none of which proved superior to this regimen developed back in the 1970s. The real addition of the anti-CD20 monoclonal antibody rituximab, which improved disease-free survival rate by about 20% in this histology. So it's really the first major breakthrough in lymphoma therapeutics. There is an international prognostic index in diffuse large B-cell lymphoma based upon age, stage, number of extranodal sites, performance status, and LDH level. In the pre-Rituxan era, many subtypes had survival rates that, many subgroups had survival rates that were less than 50%. In the post-Rituxan era, you can see that the outcome is much better. And even in high-risk patients, the long-term disease-free survival exceeds 50%. So Rituxan has really made a huge impact. And there's now a biosimilar agent of Rituxan available, which hopefully will decrease cost. Increasingly, we're relying on gene expression profiling to guide therapeutics and to guide prognosis. I always joke this looks like a brigadier general's placard. It's not really important to know these genes or even the subtypes, but suffice it to say, there are subtypes of diffuse large B-cell lymphoma, the broadest differentiation being diffuse large B-cell lymphoma of germinal center versus non-germinal center derivation. This does have prognostic importance and actually has clinical trial importance because there are agents that have differential activities in these subtypes. So like any field, our field has become increasingly complex, and what used to be one entity is now broken down into multiple entities. Follicular lymphoma is the second most common non-Hodgkin lymphoma and is the most common of the indolent B-cell lymphomas. The median age at presentation is approximately 60, and the male to female ratio in this disease actually skews towards female as opposed to diffuse large B-cell lymphoma, which skewed towards male. For localized disease, i.e. stage 1 disease, involved field radiotherapy may be curative in about 40 to 50% of patients. However, even patients who recur after radiation therapy for localized disease have a median survival that typically exceeds 2 decades. For patients with advanced stage disease with low tumor burden, observation is actually appropriate. We'll talk about that briefly. And then only patients with advanced stage disease and high tumor burden or complications of disease actually require therapy. It's a little bit counterintuitive for patients with indolent lymphomas as to why we would not treat them right away. A lot of these trials were done initially in CLL, but have been replicated in other low-grade lymphomas, including follicular lymphoma. This approach of observation has been validated both in prospective randomized trials and retrospective studies. There's no survival disadvantage to observation, or conversely, no survival advantage to immediate therapy in asymptomatic patients. At a median of 3 years, patients with grade 1 follicular lymphoma went a median of actually 48 months before requiring treatment. The higher grade, grade 2 patients often require treatment within about a year and a half of diagnosis, but many of those patients can still also go many years without requiring treatment. One of the feared complications of low-grade lymphomas is histologic transformation to a more aggressive entity. Preemptive treatment does not prevent this. I do emphasize with patients that this is an active process, so these patients do require periodic monitoring for complications of their disease and initiating treatment, so they do require ongoing monitoring by an oncologist. And in about 7% of cases, spontaneous remissions can occur, which is always gratifying when patients get better with no intervention. Indications for therapy in low-grade lymphomas include cytopenias from bone marrow infiltration, end organ dysfunction, so for instance, impending obstruction of a ureter or intestinal obstruction, symptoms attributable to the disease, weight loss, night sweats, fatigue, which is always a difficult one to gauge, bulky disease at presentation, so lymph nodes of greater than 7 centimeters we would often treat regardless of presence or absence of symptoms. If patients steadily progress during an observation period of 6 months, then that can be an indication for therapy, because those patients almost invariably develop symptoms relatively quickly, and therefore we want to intervene before they become symptomatic. Presentation with transformation of diffuse large B-cell lymphoma does require immediate cytotoxic chemotherapy, and then massive splenomegaly, which can cause early satiety and weight loss, or cytopenias, can be an indication for treatment. I'm not going to get into the therapy of follicular lymphoma, at least too many specifics. It is not curable with conventional treatment, so it is a chronic disease despite its long natural history. We don't really use CHOP too much anymore in follicular lymphoma unless there's been transformation to diffuse large B-cell lymphoma. Several studies have shown that the alkylating agent bendamustine is equally or more efficacious to CHOP in low-grade histologies and has fewer side effects such as alopecia, myelosuppression, and nausea. Maintenance rituximab is sometimes administered. This has become controversial in the COVID pandemic. Rituximab does blunt antiviral immunity. It also blunts immune response to vaccines, including the influenza vaccine. So we don't want to blunt antiviral immunity in the setting of a viral pandemic. And then although this is promissory, if there's ever a vaccine available for COVID, patients on rituximab would likely not mount an immune response and therefore may not benefit. There have been a variety of novel agents that have been introduced for follicular lymphoma. Actually, another one was just approved a few weeks ago. So increasingly, we're switching away from IV chemotherapy to oral agents. And then stem cell transplantation may be curative in this disease, but is rarely used because we have so many other options for these patients. And the toxicity of stem cell transplant remains significant. So done sometimes, but infrequently. Moving on to Hodgkin lymphoma, this is a disease of younger patients, unlike non-Hodgkin lymphoma. Most commonly, this is diagnosed in people in their late teens through early 30s, so there is a second peak in incidence starting around age 65. There are about 8,500 new cases of Hodgkin lymphoma every year in this country, with about 1,000 deaths. And about 85% of patients will survive 5 years after diagnosis. So a favorable prognosis, but still meaningful mortality in this patient population. There is an increased risk of Hodgkin lymphoma, particularly nodular sclerosing Hodgkin lymphoma in industrialized countries with a high standard of living, potentially because of delayed exposure to infectious agents. So exposure to infectious agents in childhood may, to some degree, be protective for certain subtypes of Hodgkin lymphoma. Although mixed cellularity and lymphocyte depleted Hodgkin lymphoma are more common in economically disadvantaged countries, and these are invariably EBV associated, and it may be that in these particular subtypes of Hodgkin lymphoma, exposure to EBV early in life may increase the risk of development of lymphoma. Hodgkin lymphoma typically presents with adenopathy. Most commonly, at least palpable adenopathy would be in the cervical, supraclavicular, or axillary lymph node chains. Subdiaphragmatic Hodgkin's as a standalone entity is relatively uncommon. Fevers, fairly common. Fatigue, fairly common. Weight loss, less common, but happens usually only if the patient has neglected their symptoms. Pruritus, though nonspecific, is a common symptom of Hodgkin lymphoma. And then an extremely specific symptom would be pain in lymph nodes when drinking alcohol. I'm not aware of anything else that does this. If you encounter this, particularly in a young patient, you should have a high degree of suspicion for Hodgkin lymphoma. The major issue in treatment for Hodgkin lymphoma is often not death from disease itself, but deaths due to complications of therapy. So that would be cardiovascular events and secondary malignancies, particularly in patients who've received radiation. Chemotherapy in Hodgkin lymphoma has evolved. I'm not going to talk about it too much. Suffice it to say that more intensive chemotherapy regimens have not proven beneficial, and ABVD chemotherapy dating back to the 1980s remains the standard. Radiation therapy is used less commonly nowadays, but does have important long-term side effects. There's often a long latency period of 10 to 15 years for radiotherapy-induced side effects. The risk does increase over time and is directly proportional to dose and field. So with modern radiation, doses are much lower, field is much more restricted, but we don't yet know that that translates to a decreased risk of secondary malignancy. Secondary breast cancer is definitely a greater risk in females who receive radiation to the chest and/or axilla under the age of 30. Lung cancer is an important complication, particularly in smokers. The risk of lung cancer is amplified if you've had previous chemotherapy and/or radiation and smoke versus with smoking alone. And then we do see GI malignancies, particularly esophageal malignancies from mediastinal radiation, sarcomas, and thyroid cancers. And short of thyroid cancers, also underactive thyroid in patients who've had radiation to the neck. And then cardiovascular complications are also a problem after radiation. That can really be any type of cardiovascular complication: coronary artery disease, valvular heart disease, pericardial constriction, and conduction abnormalities. So aggressive risk factor modification is important in this patient population. Early stage disease is highly curable, often now with chemotherapy alone, occasionally with the addition of low dose radiation. Advanced stage disease almost always is treated with chemotherapy alone. Sometimes radiation is used in areas of bulky disease, but that remains controversial. It's primarily these early stage patients who may get radiation and therefore who you may be seeing in your clinics with cardiovascular complications or secondary malignancies. As with non-Hodgkin lymphoma, we do have antibody therapy for Hodgkin lymphoma. Brentuximab is actually an antibody drug conjugate, so it's a toxin conjugated to an anti-CD30 antibody that delivers the toxin to the cell and kills the cell. For internal medicine purposes, this drug can cause PML. It's also an important cause of neuropathy. So you might encounter patients with significant neuropathy after receiving this agent. The addition of brentuximab to chemotherapy isn't as clearly beneficial in Hodgkin lymphoma as the addition of rituximab to chemotherapy proved to be in non-Hodgkin lymphoma. So this is a controversy in the field that I won't delve into, but we don't routinely use chemoimmunotherapy in this patient population. And then classic Hodgkin lymphoma was really the poster child for immuno-oncology, and the first setting in which checkpoint inhibitors were really, in my opinion, transformative, maybe melanoma as well. But this disease is highly sensitive to PD-1 inhibition, which restores T cell immunity against tumor cells. And there are now 2 FDA-approved agents, nivolumab and pembrolizumab, that are used as immunotherapy in recurrent Hodgkin's and being studied as a potential replacement for chemotherapy in previously untreated Hodgkin's. We'll finish up with multiple myeloma. Multiple myeloma has a high incidence in African Americans and Pacific Islanders, often arising out of previous MGUS, although prior radiation, pesticide, and petroleum industry exposure and family history do increase risk. There are about 31,000 new cases and about 13,000 deaths from myeloma every year in this country. 5-year survival is about 50%, although that's steadily improving. And just like non-Hodgkin lymphoma, this is typically a disease of patients in their late 60s and older. There are 2 broad categories of myeloma: smoldering myeloma, which is indolent, defined by low-level IgG or IgA elevations in the absence of complications from myeloma. These patients can often be observed. There are various diagnostic criteria for multiple myeloma that I've listed there. Suffice it to say that they require significant marrow involvement with plasma cells or a plasmacytoma and some evidence of end organ compromise, what are called the CRAB criteria: hypercalcemia, renal insufficiency, anemia, and or bone lesions. And so memorizing this probably is not terribly productive because the diagnostic criteria do also vary by society and by different oncology guidelines. There's a panoply of diagnostic studies that are obtained in these patients. I think for internal medicine purposes, just recognizing that hyperviscosity can be an issue. Cryoglobulinemia can also be an issue. And then secondary amyloidosis typically occurs in the later stages of disease, but often is diagnosed by cardiologists or other specialists within internal medicine, and is one of the more feared complications of multiple myeloma. The staging system for multiple myeloma is fairly straightforward. It's based on beta-2 microglobulin and serum albumin. And patients with early stage disease have a fairly favorable prognosis. Patients with stage 3 disease, less so. But again, that's changing with the advent of new therapies. There are a variety of factors that, in addition to beta-2 microglobulin and albumin, that affect risk. Not surprisingly, older patients with poor performance status have a poorer prognosis. There are a number of different genetic and molecular abnormalities that are associated with adverse prognosis. I'm not going to go through them, nor is it worth your time to memorize them. And again, evidence of end organ damage, particularly kidney injury at diagnosis, is an adverse prognostic feature. Other complications, so bone disease, pathologic fractures, fairly common, particularly vertebral fractures, but other bones can be affected. As I mentioned, hyperviscosity, more so with IgM because it is a pentamer and therefore more viscous. Recurrent infections, renal failure from a variety of different causes, particularly IV iodinated contrast. So give contrast to these patients with caution. Cardiac failure from amyloid or hyperviscosity or anemia. Anemia is almost by definition present in multiple myeloma. And then a variety of different sensory and motor neuropathies can occur in these patients. I'm not going to go through these different treatments, but suffice it to say the prognosis for these patients has improved dramatically over the years, and median survival in many settings now exceeds a decade. Treatment, bisphosphonates are a cornerstone of treatment for bony disease. There are a variety of different regimens that are used in non-transplant candidates, mostly surrounding immunomodulatory agents such as lenalidomide. And then autologous transplant is sometimes used, and these patients often receive aggressive free drug combinations prior to transplant. A brief note on stem cell transplant: it prolongs remissions, but there's no clear improvement in survival, so the field may be moving away from transplant in these patients. Patients after transplant often get maintenance lenalidomide, which does increase the risk of secondary malignancies. So important when you see these patients in clinic to be cognizant that they can get skin, GI, and other malignancies. And then rarely do we perform allogeneic transplant anymore. So to summarize, non-Hodgkin lymphoma often presents with lymphadenopathy, but any organ can be involved. Excisional biopsy preferred, but core biopsy is acceptable. Staging is universally done with CT scan, often now with PET scan. Bone marrow biopsy still has a role, but less commonly. As a general truism, aggressive lymphoma is potentially curable with chemotherapy. Indolent lymphoma is not curable, but generally with a very, very long natural history, most patients lead a normal life expectancy. Hodgkin lymphoma presents in younger patients, typically in the neck and mediastinum. Generally a high cure rate, and the field has really looked at minimizing long-term morbidity and mortality from late complications from treatments. The field has looked at de-intensifying treatment. Multiple myeloma, the diagnosis requires at least 10% plasma cells and evidence of end organ dysfunction. Cornerstone of treatment is immunomodulatory agents, most commonly lenalidomide. Important complications of lenalidomide therapy can be secondary malignancies, venous thromboembolism, and rash. And then some patients proceed to stem cell transplant, again, less commonly, at least briefly in the COVID era, because of the desire to avoid immune suppression in these patients when there is, as of yet, no overall survival advantage with transplant in multiple myeloma.
Great. So, Eric, thank you so much. We're actually going to hold off on your practice questions, and we're actually going to move to the Q&A portion. It's not your fault. We were running a little bit late, so you caught us up. So thank you so much, Eric.